Hi everyone, I am Dr. Divya Shanthi and welcome to NEET PG Core Revision series. These series are structure focused and exam oriented so that you can recall faster and more confidently in your exams. In today's session, we are going to break down the anatomy of the tongue into clear, high-yielding, exam-focused concepts. So let's get started. So the tongue, as we know, is a mobile muscular organ, which is basically made up of muscles covered by a mucous membrane. So, and it is present in the oral cavity. So, it's a muscular organ which is situated in the oral cavity. So, when we see the tongue, so it bulges upwards from the floor of the mouth, and its posterior part here will be forming the anterior wall of the oropharynx region. Now, why is the tongue important? The tongue performs other than the taste, we need the tongue to taste the food, for speech, for mastication as well as for deglutition. So, for taste, for speech, for mastication and deglutition, we require the tongue. Now the tongue, when we see the shape of the tongue is conical in shape. Is conical in shape and it is elongated. It is elongated antero-posteriorly and flattened dorso-laterally. Dorso-ventrally it will be flattened. Now when we see the tongue, it has a root, so it has a root which is attached here to the mandible and the hyoid bone. So it will have a root, it will have a tip, that is the anterior end of the tongue, which will come in contact with the incisors, central incisors, and then we have the body. So this portion is the body of the tongue. So these are the three parts of the tongue, the features of the tongue. Now the body of the tongue is basically the portion of the tongue between the tip and the root. Between the tip and the root will be the body. So this body will have two surfaces, the dorsal surface which we see here up, this will be the dorsal surface, and the ventral surface. So the dorsal surface of the tongue here will be convex on all the sides. So it is convex on all the sides and it is divided here. If you see, this is the V-shaped sulcus. The V-shaped sulcus here, which will divide it into two parts, that is, it is divided into anterior 2/3 and posterior 1/3. So this anterior 2/3 forms the oral part of the tongue. So it is present in the oral cavity, whereas the posterior 1/3 will be the pharyngeal part of the tongue. So this is in the oropharynx region, pharyngeal part, whereas this is the oral part of the tongue. So here this sulcus terminalis, this V-shaped sulcus, we call it as the sulcus terminalis. So this will have a foramen here which we call it as the foramen cecum. So that is the site from where the thyroid gland, that is the thyroid diverticulum, 𝗙𝗏𝗏glossal duct will be, 𝗙𝗏glossal duct which forms the thyroid gland will be developing in the embryonic life. Now here the oral part, so here if you see the oral part, it will have a median furrow, so this is the median furrow. So basically it represents the two swellings, the lingual swellings will join to form a single tongue, so this is the part representing the bilateral origin of the tongue. Then it will have large number of papillae, so in the dorsal part of the tongue there are a lot of papillae which are present, whereas the pharyngeal part, so here we will see the furrow, median furrow, and we will see papillae. Then in the pharyngeal part of the tongue here, there are, if you see, there are large number of lymphoid follicles, so the pharyngeal part which forms part of the anterior wall of the oropharynx. Here it will have a lot of lymphoid follicles, which we call them as the lingual tonsil. Okay, so this is the lingual tonsil. In addition to that, there will also be large amount of mucus and serous glands are also present there. So that is the features which we see in the dorsal surface of the tongue. So at this junction here, okay, the oropharynx part and oral part and the pharyngeal part here, we have one fold here, okay. So that is the palatoglossal fold here. So, and behind will be the palatopharyngeal fold. So between that, there will be a tonsillar fossa which will be lodging this palatine tonsil. So which are the papillae we see on the oral part of the tongue, or the anterior 2/3 of the tongue, which we call it as the lingual papillae. So they are basically the projections from the lamina propria of the mucous membrane. So here the largest papillae, we call them as the circumvallate papillae. Okay, circumvallate papillae. So these circumvallate papillae, they are present, they are about 8 to 12 in number, and they are arranged in a V-shaped row in front of the sulcus terminalis. So in front of this sulcus terminalis, we see them, okay, this large papillae, which we call it as the circumvallate papillae. Then we have the filiform papillae. So this filiform papillae are present, they are the smallest, okay, smallest papillae which we see, and they are present all over the tongue, present with pointed tips, they are present all over the tongue. And histologically, when we see, they are covered by keratin, and that provides a rough surface to the tongue, which prevents the slipping of the food, okay, over the tongue. So that is, we see the filiform papillae. So they are the most numerous papillae, okay, narrowest and numerous. Whereas this is the largest, circumvallate is the largest papillae. Then we have the fungiform papillae. So the fungiform papillae usually we see more at the apex and at the margins. We will see that is fungiform papillae, like shape of a mushroom kind of thing. Okay, so they are the like pink headed. In the living we can see in our tongue like pink small headed papillae. This is the fungiform papillae, like pink pinheads, they appear to the eyes. Then we have foliate papillae. So these foliate papillae, they are very inconsistent. They are in front of this, at the margin of this, along the margins in front of the sulcus terminalis here, we can see, okay, that is the foliate papillae. So foliate papillae, they are basically rudimentary in humans, okay. So mainly in humans, we see the circumvallate, the fungiform and the filiform papillae. The foliate papillae are rudimentary in humans, okay. And among these three, that is circumvallate, filiform and fungiform, filiform doesn't have any taste buds, but instead it is covered by keratin. Whereas circumvallate and the fungiform will have taste buds. Circumvallate will have it along its lateral margins, the taste buds, and the fungiform will have it at the apical surface. So, and in addition to this, there is one more type of papillae, we call it as the papillae simplex. So this papillae simplex, they can be seen only under the microscope. Then coming to the inferior surface, okay, so inferior surface of the tongue when we see, okay, so it is covered by this portion, it is located in the oral cavity, and here it is lined by the mucous membrane, which gives it a very shiny appearance, and this mucous membrane is very thin, okay, it's very thin, smooth, and it looks purplish because of the underlying veins there which are present. So this, when we trace it down, this mucous membrane is reflected onto the floor of the mouth. So here we can see few features, that is median fold of mucous membrane we can see here, which we call it as the frenulum linguae. Okay, so frenulum linguae is the median fold, and through this, okay, so this frenulum linguae will be connecting, okay, the tongue to the floor of the mouth here. Then we have deep lingual veins on either side of this frenulum linguae. We will see here we can see these are the deep lingual veins. So that is, here we can, this fold we call it as the plica fimbriata. So it is present lateral to this lingual. These are the lingual veins. So lateral to these lingual veins, we see the plica fimbriata. Okay. So this is the features which we see on the ventral surface of the tongue. So here sometimes what happens, this frenulum, okay, it extends. So usually the frenulum, it connects, it doesn't extend up to the tip of the tongue. It just stops midway, okay. But sometimes it will extend all the way to the tip of the tongue and it attaches it to the floor of the mouth. So this we call it as the tongue tie. So this here, this is the tongue tie. Okay. So this is called the tongue tie. So when there is tongue tie, it prevents the movement of the tongue within the mouth. Okay, they cannot extend the tongue, and certain syllables while talking, they are not able to pronounce it, whichever where the tip of the tongue needs to touch the palate, like la, ta, these kinds of syllables, they will not be able to say, okay, because of this tongue tie. So ideally, before the child starts speaking, if this condition is there, it needs to be corrected so that the speech develops normally. So it is corrected by cutting the frenulum surgically, okay. And this surface of the tongue, the ventral surface of the tongue, right, since it is covered by thin mucous membrane and we have the lingual veins, so certain drugs which are lipid soluble, right, they can easily diffuse through this mucous membrane lining this region, okay. That is why we use this vasodilator, right, vasodilator drugs like the nitroglycerin. So nitroglycerin, in case of angina pectoris, it is placed beneath the tongue where it is rapidly absorbed, okay, and the symptoms are relieved. Then the taste buds are distributed all over the tongue, okay. So basically I told you the circumvallate papillae has the taste buds, then we have the fungiform papillae along the lateral margins, which also has the taste buds. So in the taste, at the tip of the tongue, okay, tip of the tongue, we feel more of sweet taste is felt here. Then here anterior part along the margins, we feel more of salt taste, salty taste is felt there. Then here behind we feel sour along the margins, and the posterior most part here we see bitter is felt more, okay. So generally these tastes are felt more in these regions. So since the tongue is mainly muscular organ covered by the mucous membrane, the muscles of the tongue form the main bulk there. So here we have two types of muscles, the intrinsic and the extrinsic. Okay, so intrinsic muscles which have the origin and insertion within the tongue itself, whereas the extrinsic muscles have the origin elsewhere and they get inserted around the tongue region. So tongue is, here if you see, is divided into symmetrical right and left halves by the median fibrous septum, right? And on each half of the tongue will have 4 intrinsic muscles and 4 extrinsic muscles. So which are the extrinsic muscles of the tongue? So the extrinsic muscles of the tongue, we have the genioglossus, then we have the hyoglossus. Okay, so this is the hyoglossus. Then we have the palatoglossus. Which we see it in the fold, right, which forms the anterior fold for the tonsillar fossa, so palatoglossus muscle. Then we have the styloglossus. Styloglossus muscle. So the genioglossus muscle, we call it as the safety muscle of the tongue. Okay. So this is the safety muscle. Safety muscle of tongue. So this genioglossus, because the two genioglossus muscle, okay, because they are all in pairs. All these muscles are in pairs. So the two genioglossus muscle, it forms the bulk. So if you see, it is forming the bulk of the tongue. Okay, and they are responsible for the protrusion of the tongue. So when this genioglossus muscle is paralyzed, okay, what will happen? The tongue will fall back and will obstruct the oropharynx. Okay, that will lead to choking and death. Right. So that was about the extrinsic muscles. When coming to the intrinsic muscles of the tongue, so intrinsic muscles of the tongue, we have the superior longitudinal, then we have the transverse, inferior longitudinal, so superior longitudinal, inferior longitudinal, transverse, and then there is the vertical muscles. Okay, so vertical muscle will be here. It will be running vertically like this. So that is the 4 intrinsic muscles which are present within the tongue. So they basically produce the different shape of the tongue. Okay, so either flatten the tongue or lengthen the tongue, shorten the tongue. So that is what these intrinsic muscles of the tongue do. So the coming to the nerve supply of the tongue, okay, the somatomotor supply, that is basically the motor supply of the tongue. So the motor supply of the tongue is mainly by the all the muscles, whether the intrinsic or the extrinsic muscles, they are all supplied by the hypoglossal nerve. So here there is an exception. So you have to remember all intrinsic and extrinsic muscles are supplied by hypoglossal except which muscle? Yes, palatoglossal, except for palatoglossal. And what is it supplied by? The cranial part of accessory, cranial root of or cranial part of accessory nerve. Okay, so through the pharyngeal plexus, cranial part of accessory nerve, that is the 11th cranial nerve, will supply. So all the intrinsic, extrinsic supplied by hypoglossal except for palatoglossal supplied by the cranial part of accessory nerve. So this is important, which you have to know. The secretomotor fibers here, mainly by, here we have the tractus solitarius nucleus. Okay, this is the nucleus, tractus solitarius. So from here, okay, through the, we have, this is the superior salivatory nucleus. So here two nucleus we see in relation to the brainstem here, that is the pons and the upper part of the medulla. Here we see the nucleus tractus solitarius as well as the superior salivatory nucleus. So from here begins, okay, so we have the special visceral afferent fibers. Special visceral afferent fibers, these are the special visceral afferent fibers which carry the taste sensations. Special visceral afferent fibers, okay, they carry the taste sensations. And then we have the general visceral afferent fibers. So basically general visceral afferent fibers, they help in the secretion of the saliva there. They are basically through the salivary glands and through the lingual nerve. These fibers are carried through the lingual nerve. And special visceral afferent fibers is basically the taste sensations from the anterior 2/3 of the tongue, which is carried by the chorda tympani nerve. So here we have the chorda tympani nerve. So this chorda tympani nerve is a branch of facial nerve. This is the facial nerve. This is carried by the lingual nerve, and through the lingual nerve basically carries the general sensations from the tongue. Okay, so general visceral afferent sensations are carried by the lingual nerve, and special visceral afferent are carried by the chorda tympani nerve. So that is about the secretomotor fibers. So here when we see the sensory supply of the tongue, okay, so sensory supply of the tongue basically supplying the mucous membrane of the tongue. So here, since the tongue has developmentally, okay, the anterior 2/3 of the tongue is developed in relation to the first pharyngeal arch, that is from the two lingual swellings and the tuberculum part, whereas the posterior 1/3 of the tongue is developed in relation to the third and fourth arch, that is the we have from the upper cranial part of the hypobranchial eminence. So because of which the nerve supply differs. Okay, so here when we see the sensory supply of the tongue, so the anterior 2/3 develops from the first pharyngeal arch. So because of which it is supplied by the lingual nerve. So lingual nerve basically it is the posttraumatic branch. Lingual nerve is a branch we have from the mandibular nerve. So the anterior 2/3 of the tongue is formed in relation to the first arch, and the nerve of the first arch is mandibular nerve, and lingual nerve is a branch of the mandibular nerve. Okay, it's a posttraumatic branch of first arch. And so lingual nerve carries the general sensations, and then we have the chorda tympani, which is the pretraumatic nerve. So it is basically branch of the facial nerve which supplies the basically carries the special sensations from the anterior 2/3 of the tongue. So it is the chorda tympani nerve. So this chorda tympani nerve we call it as the pretraumatic nerve of first arch. Okay, so this one is going to carry the special sensations of taste, whereas the general sensations of temperature and other sensations, okay, touch, pressure, temperature sensations, they are carried by the lingual nerve. Then the posterior 1/3 of the tongue, okay, posterior 1/3 of the tongue is developed in relation to the third arch. Third arch, and the nerve of the third arch is the glossopharyngeal nerve. So here the glossopharyngeal nerve carries both the general as well as the special sensations. That is what you need to remember. And the posterior most part of the tongue is developed from the posterior most part is from the fourth arch, and the nerve of the fourth arch is the internal laryngeal nerve. Internal laryngeal nerve. So that part is supplied by the internal laryngeal nerve. Okay, so that is about the sensory innervation of the tongue in relation to its development. Coming to the blood supply of the tongue, tongue is supplied by branches of lingual artery. Okay, so lingual artery is the chief artery of the tongue. Lingual artery is the chief artery. Okay, so it is the main artery, and its branches will be supplying the tongue. Then other than this, we have the tonsillar, okay, tonsillar branches, tonsillar branch of facial, as well as the tonsillar branch of facial artery, and ascending pharyngeal artery. Okay, so So lingual artery, tonsillar branch of facial artery and ascending pharyngeal artery supply the tongue. And this lingual artery will be giving the deep lingual arteries to the anterior part as well as the dorsal lingual arteries to the posterior part. Okay. So here is the anterior part, we will see the deep lingual arteries, and to the dorsal part here we will have the dorsal lingual, that is the posterior part, we will have the dorsal lingual arteries. So these deep lingual arteries, right, they will anastomose with the similar branch from the opposite side. So that is the only anastomosis which will occur, okay, across the midline of the tongue. Otherwise there is, because the two parts are formed from two different swellings, right, so they will have their own individual thing. But this part here, only the deep lingual arteries will be anastomosing with each other along the midline. The venous drainage is basically follows the arteries, the veins. Okay, so we have the deep lingual vein, which is the principal vein of the tongue. Okay, deep lingual vein is the principal vein of tongue. So this is, if you see, it is visible on the ventral surface of the tongue. Then we have venae committents, the other veins, venae committents accompanying the lingual artery. So venae committents accompanying accompany the lingual artery. They are joined by the dorsal lingual veins, okay, as well as the venae committents accompanying the hypoglossal nerve. So they are also present. So all of them, they all join to form the lingual vein. So all of this together, they will form the lingual vein. And this will drain into the either common facial. So it drains into common facial, or it may drain into internal jugular. Okay, common facial or internal. Okay, so there is the deep lingual vein, which is the principal vein. Then we have the venae committents accompanying the lingual artery. They join the dorsal lingual veins. Then we have also the venae committents along the hypoglossal nerve. So all of them join together, they form the lingual vein. And this lingual vein will drain either into the common facial or it will drain into the internal jugular. Next important is the lymphatic drainage of the tongue. So here the lymphatic drainage of the tongue is basically, okay, so this is the jugulo-digastric group of lymph nodes. Then we have the jugulo-omohyoid. Then we have the apical, this is submental here. Then we have the submandibular. Here apical as well as the apical and submental will be there. Okay, so in the midline. So these are the group of lymph nodes which will be draining the tongue. So now we group them into 4 sets. So one is the apical vessels. Okay, so the apical vessels here, they will be draining the tip of the tongue, the tip and the inferior surface of the tongue into the submental group of lymph nodes. Okay, so the apical vessels. So we group them into apical vessels. So the lymph vessels are, first is apical vessels which drain into submental. So basically they are draining the tip and the ventral surface of the tongue. So from there they either go to the submandibular group of lymph nodes or they cross and they go to the jugulo-omohyoid group of lymph nodes. Okay, they cross the hyoid bone here, go to jugulo-omohyoid, or they go to the submandibular. So that is how they finally drain. Then we have the marginal vessels. So marginal vessels, they drain the marginal portion of the anterior 2/3 of the tongue. and there if you see they all go to, they are unilateral, okay, they are unilateral. So from either side they go to the submandibular group of lymph nodes, and then from there to the lower deep cervical group of lymph nodes, including the jugulo-digastric, jugulo-omohyoid, they go, okay, so along the margins. So this is the draining the anterior 2/3 of the tongue on either side, okay. So this is the marginal vessels. So apical vessels, marginal vessels. Then we have the central vessels. The third group is the central vessels. Now the central vessels, they drain the central portion, okay. So if you see, these are the central group. So we have the apical, then we had the marginal, this is the central. Now the central portion of the anterior 2/3 of the tongue, okay. So this will pass downwards in the midline of the tongue between the genioglossus muscle, and they drain into the deep cervical group of lymph nodes, okay. That is, the central group will be draining into the deep cervical group of lymph nodes. And then we have the basal vessels here. Basal vessels basically will be draining the root of the tongue, okay, basal vessels, root as well as the posterior 1/3 of the tongue. So this will be draining into the upper deep cervical group of lymph nodes, including the jugulo-digastric group of lymph nodes. So that is the lymphatic drainage of the tongue. Now here what we have to understand is, in tongue cancer, how the tongue cancer can spread through these lymphatics. To understand that, understanding of these lymphatics is important. So just to repeat, the tip of the tongue, here tip of the tongue, the inferior surface and all, it is drained into the submental group of lymph nodes. Then we have the marginal draining into the deep cervical group of lymph nodes, including the jugulo-omohyoid. Then the central group, they going to the deep cervical group of lymph nodes, okay. And then we had the basal, that is draining the root as well as the posterior 1/3 of the tongue, which goes to the jugulo-digastric group of lymph nodes as well as upper deep cervical group of lymph nodes. Now this tongue here, since there is a rich anastomosis across the midline between the lymphatics, okay. So here the lymphatics of the posterior 1/3 of the tongue, what happens is they will anastomose, okay, with each other from two sides. So here you have to understand, the posterior 1/3 of the tongue is formed from just the cranial part of hypobranchial epinus. This is just one structure, okay. So because of which here the lymphatics, they anastomose, unlike the anterior 2/3, okay. So the cancer from one side, it can metastasize to the same side as well as to the opposite side, okay, through these lymph nodes because of the anastomosis of the lymphatics. So in the anterior 2/3 of the tongue, okay, in the anterior 2/3 of the tongue, there is no cross, there is no communication of lymphatics. So here it does not metastasize, so it is only to the same side. Ipsilateral spread is there, but not contralateral spread doesn't happen in case of anterior 2/3 of the tongue, whereas posterior 1/3 of the tongue is contralateral spread can happen, okay. So from one side to other because of the communication between lymphatics. And here you should also remember that the anterior 2/3 of the tongue cancers are more common than the posterior 1/3, and posterior 1/3 cancers have very poor prognosis because of the communication there and spreading the contralateral side, whereas anterior 2/3 of the tongue has good prognosis compared to the posterior 1/3. So coming to the image based MCQs, the structure marked divides the tongue into parts. So what is parts derived from? Okay, derived from what? The sulcus terminalis marks the parts derived from the first and third branchial arch, okay. Here you have to understand that during the development of the tongue, okay, the second arch gets buried and the third arch becomes more prominent there. So that is why we don't consider first and second arch. So remember that we say first and third arch, okay, pharyngeal arches. Then these papillae are supplied for taste bud by, okay. So these papillae is basically these ones, it has marked circumvallate. So circumvallate papillae are basically supplied by glossopharyngeal. Okay, this is one more thing. Glossopharyngeal nerve carries the taste sensations from the posterior 1/3 as well as from the circumvallate papillae also. Okay, though it is located in the posterior most part of the anterior 2/3 of the tongue. Then all intrinsic muscles of the tongue are supplied by hypoglossal nerve. Yes. Here see, the question is all intrinsic muscles. All extrinsic muscles are supplied by hypoglossal except for palatoglossus, which is supplied by the cranial part of accessory nerve. Lymph from the central of anterior 2/3 of the trunk drains primarily to, okay, central anterior, it goes to the deep cervical group of lymph nodes. Deviation of the tongue to the right side indicates injury to, yes, the right hypoglossal. So, because it is deviation to the same side in hypoglossal nerve injury, it is deviated to the same side of lesion. So, that is all about the anatomy of tongue. So, stay consistent with the series because consistency is the key to success. I will see you in the next session.